Good afternoon, everyone, and welcome to our virtual health talk. My name is Melissa, and my pronouns are she, her, and hers. On behalf of the Patient Education and Engagement Program here at the University Health Network, I would like to thank you for attending today's session, Planning for My Future Care, How Palliative Care Can Help. Before we get started, we'd like to share some information about the MyUHN patient portal. As you may have heard, UHN is preparing for a clinical transformation, launching a new health record system and patient portal on June 4th, 2022. If you're a current MyUHN patient portal user, there will be a few things that you need to do for a smooth transition to the new portal. The first is to sign into your MyUHN account between now and June 3rd. Signing into your account during this period will make sure your email and password are transferred to the new patient portal. You can find more information about UHN's clinical transformation on uhn.ca, or please reach out to the patient portal support team by phone at 416-340-3777 or by email at myuhn.ca. Thanks, everyone. Now going back to our health talk, I would like to take a minute to thank our planning team. So first, the Patient Education and Engagement Program, the Patient Learning and Experience Centers, and Education Technology and Media Services. A few words about our online format today. This session is being recorded and will be available for viewing with closed captioning at the same YouTube link afterwards. Today we'll have a presentation for approximately 38 minutes, and then we'll open it up to the audience to ask questions for the rest of the session. If you have any questions about the live stream during the session, you can email us at pfep@uhn.ca or leave a voicemail at 416-603-6290, and a member of our team will get back to you shortly. On the topic of technology, we realize anything can happen when it comes to internet connections. So with that said, should my connection cut out at any point, have no fear, you'll be seeing one of my awesome colleagues step in to facilitate the session. We also want to note that some of our speakers are presenting on site at the hospital. So because of that, you may hear overhead announcements or alert codes in the background, in which case we'll pause for a few seconds until they're complete. To submit your questions to the presenters, we invite you to go to the link on your screen, and it's also in the description box below. You can also scan the code using your smartphone's camera or QR code reader app, and you can submit questions anytime during the presentation. And we want to quickly thank those who have submitted questions already. It helps us see what people are interested in learning about most. And we have tried our best to address these within the presentation, but we can definitely summarize them very quickly during the question and answer period as well. When you submit your questions, you might notice that it doesn't get posted right away. This is because we're now reviewing questions before they show up for the audience. This helps us make sure that questions won't be repeated. We can help clarify them, and we can have a bit more time to address new and different questions. It also gives us a chance to prepare how the questions will be answered before they're posted. We just ask you to please keep in mind a couple things before you submit your questions. First, you can choose to include your name or stay anonymous, but please note that others will be able to see your name if you do include it. We ask that you do not include any personal details about your health or condition in your question. Our health talks are for general health information only. So the speakers are not here to diagnose or provide treatment recommendations. And we'll try to answer as many questions as we can during the question and answer period. And lastly, you can also vote for your favorite questions by clicking the thumbs up button, and this will help bring questions closer to the top and they'll more likely be answered. We're excited to also let you know that you can enter for a chance to win a $10 Tim Hortons gift card. And to do so, you just have to fill out a feedback survey after the talk. This draw will close in a week on Thursday, May 5th at 2:00 p.m. and we will draw the name and notify the winner on Friday, May 6th. So please make sure to enter your email address correctly and to check your spam or junk folders. So now you're probably wondering, how do I fill out a feedback survey? You would just have to go to the link on your screen and complete the survey at the end of the health talk. This link is also in the description box below, or you can use your phone again to scan the code. After you complete your survey, you'll see a link on the confirmation page to enter the draw. We thank you in advance for filling this out. It really helps us know what you liked, what we can improve on, and what topics you would like to see in the future. Okay, so now moving on to our presenters. First, we will hear from Karen Solomon, who is a retired psychologist and who was on the staff as a therapist for almost 25 years at York University in the Counseling and Disability Services. She's speaking here today as a caregiver, daughter, and partner. Next, we'll hear from Dr. Warren Lewin, who is an assistant professor in the Department of Family and Community Medicine at the University of Toronto and is the site lead for the Palliative Care program at Toronto Western Hospital. He trained and worked in both Canada and the US and enjoys teaching communication skills to healthcare providers so that patients and families have access to clinicians that know how to engage in high quality conversations about what matters to them most. Next, we'll hear from Dr. Ebru Kaya, who graduated from Guy's and St. Thomas's Hospitals Medical Schools in London, UK in 1998 and entered her career in internal medicine and later went on to specialize in palliative care. She has been working at UHN since 2007. Currently, she's the site lead physician for palliative care at Toronto General Hospital, the interim director for the Division of Palliative Medicine, and the president-elect of the Canadian Society of Palliative Care Physicians. And then we'll hear from Dr. Breffney Hannon, who graduated from medical school at University College Cork in Ireland and went on to complete training in general practice, followed by palliative care before moving to Toronto in 2011. Here she completed two more years of training in palliative care research before joining the team at the Princess Margaret Cancer Centre as a staff physician in 2013. She is currently the site lead for palliative care at Princess Margaret and is the research lead for the Departments of Palliative Care and Palliative Medicine at the University of Toronto. So we have an awesome group of speakers today. And before I turn it over to them, I would like to take a moment to acknowledge the sacred land on which the University Health Network operates. At UHN, we strive to provide safe and inclusive care, and that begins by honoring Indigenous peoples. Indigenous peoples are the original inhabitants of this land and for thousands of years have cared for this land. Although we're presenting this health talk in the digital world today, we want to acknowledge and remind ourselves and also encourage you to do so too, wherever you're currently located, that we are still on the traditional territory of many nations, including the Huron-Wendat, the Haudenosaunee, and the Mississaugas of the Credit River. This territory is governed by the Dish with One Spoon Wampum Belt Treaty, an agreement to share, care for, and protect the resources around the Great Lakes in peace and respect. Today, this territory is still the home to many Indigenous peoples from across Turtle Island, and we're very grateful to have the opportunity to work, learn, and play on this territory. So now enough from me. I'll now turn it over to Karen, who will be starting us off.
Thank you so much for this opportunity to speak about my experiences with palliative care and advanced care planning. My strong connection with the University Health Network started in 2009 when my partner, a longtime philanthropic supporter of palliative medicine, introduced me to the palliative care team working with Dr. Michael Baker. I was able to attend meetings where training, research, and clinical practice were discussed, and was fortunate to meet doctors in many different specialties from Canada and from around the world who had been given fellowships to UHN to train in palliative medicine as clinicians and researchers. I think many of them came expecting to go back to their home countries, and probably our good fortune, many of them stayed in Toronto. At that time, I would describe myself as the most interested learner, eager to tell others about the amazing work that was being done in palliative medicine. I had worked years ago in a rehab facility, so was familiar with psychological approaches to pain management, anxiety and depression, and post-traumatic stress disorder. Things changed, however. Around 2011, my mother was diagnosed with acute myeloid leukemia. Things changed for me, and I became the caregiver. In my family, no one discussed retirement, long-term plans, or anything close to advanced care planning. Although my grandmothers died, one in her 60s and one in her 70s, both at home, everyone else died in their later 80s or 90s, often still working part-time. They died at home with personal support care workers or nursing care, or at most spent their last few weeks in hospital. My dad worked until he was 83, collapsed and died suddenly at 86. At the time that my mother became ill, she was about 93 and still helping her colleague with some editing and other administrative services. So end-of-life plans were not discussed, and I was not prepared. My mother did have a palliative care doctor in the early stages of her disease and did live about a year longer than expected, but neither she nor my family members were ready to discuss the future, and I think that added a great deal of stress to all of us. When my mother was admitted to Toronto General Hospital for a platelet infusion and hoped to go home, it was determined that she needed to be admitted to the hospital and was not expected to live more than a few weeks. At that time, I met Dr. Ibu Kaya, who was called in from the palliative care team. How lucky for our family that Dr. Kaya was assigned to my mother's case, and Dr. Baker was there in the background for us as well. I wanted to take my mother home and knew that's what she would want, although she was not saying much at that time and seemed to be leaving decisions to me. Dr. Kaya said one thing that has stuck with me when we were discussing all the services that would be involved if I took my mother home. And she said, if your mother goes to a palliative care facility, you get to be the daughter while others take care of your mother's needs. And so it was. And she received wonderful care in the Princess Margaret Palliative Care Unit with staff from many departments. They offered much needed support to me and to our family. That comment from Dr. Kaya became even more clear 5 years later when my partner was unexpectedly dying at home. We had an excellent palliative care team from the Temi Latner Center, but there was still the scheduling of double shifts of personal support workers, doctors and nurses coming and going, pharmacies calling and sending supplies. So I was the partner and the caregiver, and it was stressful. So looking back, what have I learned? Planning is important. You might not get to choose how the end of your life will look, but planning and knowledge will give you and your loved ones an edge. Palliative care can happen in many ways and places. Each case is unique. Some people stay in their homes, others do not, and others cannot. Know that palliative care does not have to start during the final few weeks of life, but when a life-limiting diagnosis is made. It's never too early to start these conversations so that you know what wishes and values your loved ones have, and they know the same about you. I would recommend learning about advanced care planning when you do your will or sooner, and when you appoint your power of attorney for healthcare. Think about the conversations you might be having for yourself or with loved ones before you or they end up in emergency, and staff begin to ask you the questions. What about do not resuscitate orders, and what other wishes do you have? Discussions about serious illness, death, and dying can be sensitive and difficult. A few of the resources that my friends and I have found, and a lot of us have been talking, especially since COVID, and especially since many of us are now single. Speak Up Ontario is a resource guide for you and your substitute decision maker, and includes possible conversations you might have in Emerge, which I thought would be helpful to think about in advance because medical staff will be asking these questions. Planwellguide.com is also an excellent planning tool which allows you to document your wishes, change them as required when there are major changes in your life. Your wishes at age 29 with young children might well change when you are 75 or 80. Again, thank you for this opportunity to share some of my experiences.
Thank you so much, Karen, for sharing your experiences and resources with us. Hearing your story certainly helps us better understand why advanced care planning is so important. So thank you so much. So now we'll hear from the UHN Palliative Care Site Leads who will build on what we learned from Karen and talk a little bit more about the benefits of advanced care planning, how to begin your own plan, and how palliative care can help. And they'll also share some more resources at UHN and in the community. So now I'll hand it over to Dr. Warren Lewin.
Hi, so thanks so much for having our team here today. And thanks, Karen, for sharing such a personal experience with everybody. And hopefully what Dr. Kaya Hannon and myself can do is speak a little bit more in detail about advanced care planning and give you some practical tools that you can leave here with to begin planning for yourselves or your loved ones. So we're going to start with a video just that can illuminate this a little bit.
I would guess there's a big percentage of people don't like to talk about it. And there's a big percentage of people that it happens suddenly, you never get a chance to talk about it.
Well, of course, we are from the age that things weren't talked about.
It's not part of, hey, what'd you have for supper last night?
You've got to know what to do, what you want done.
We have to talk about this. We should talk about it so that when and if this happens, you get the care that you want.
The same day I came in, they told me I had leukemia. You can't see the leukemia going away. My wife and I have talked about pretty well everything.
Well, we did talk when you were in the hospital.
Oh yeah, I guess
And you
so.
did make the decision. We've talked since then and before that a little bit.
What did I decide?
You decided that you didn't want any CPR and that you didn't want resuscitation.
I still think that.
It's very difficult for a family member to make that decision if there's been no discussion. Most of the time we wait too late. We're often in a critical situation when we're asking those questions.
So it is new to us to talk openly about private things. I think it takes a while to get comfortable because it is a privacy thing, eh? Even with your own family. It's not so simple to say what you want or what you don't want.
We're in a situation where we're having to communicate with family members about decisions to either apply or continue or withdraw life-sustaining treatments. Frequently you hear, oh, I don't know what mom would have wanted. Mom never told me or mom never talked to me about this. And so the family then in that acute moment has to struggle with helping us make decisions with what mom would have wanted. And it would have been so much easier had mom communicated to her family in advance what her wishes, what her preferences, what her values would have been.
All right, so hopefully that video sheds a little light on the topic from people experiencing the healthcare system. And now we'll move on. Wanted to recommend reading for everyone. If you haven't seen or read this book, Being Mortal by Dr. Atul Gawande, it's a great way to learn more about this topic in a very humbling way from a surgeon who spent years and years providing cure to people and then was faced with a loved one with serious illness. And next slide. And he's a writer. I think he's on television a lot now as well. But he interviewed many families about their experiences with frailty, aging, and serious illness, and spoke to people who are experts in the field who have conversations every day about the future, and that's people in palliative care. And what he learned years into practice was that there were two main things. One, in medicine and society, we failed to recognize that people have priorities to serve besides just living longer. We're trained to help cure people, and what he learned from these people is that we can help people and people want to live better, not just longer. And the most reliable way to help people live better is to ask them what matters to them. And it's unfortunate that most of us in healthcare are just not taught how to do this. And Karen mentioned that these are sensitive conversations. And so when people don't feel confident having these conversations, they shy away from them and they don't often happen. So there's a lot of work at UHN that's being done to help fill this education gap. And next slide, please. We know that we need to do this because Canadians are comfortable talking about end-of-life care and their related issues. The issue is that they're not talking to healthcare providers about this. Next slide. It's not because people aren't bringing it up, although many don't, but it's also because we don't ask. And so today you'll hear from Dr. Kaya in a bit about questions that you can begin thinking about and asking. Next slide, please. There are many benefits of talking about what matters. Ultimately, it gives you better quality of life and can make you feel less stressed and those people around you that you love and that love you. Having a roadmap of what matters to you can just take away a little bit of the anxiety when we know what to expect in the future. And so having tough conversations up front can make things easier down the road. And ultimately, it helps you get the care that you want in the way that you want it. Next slide, please. So what is advanced care planning? It's a process of thinking about what matters most to you. And it helps ensure that the care that you get in the future is aligned to what you want. And in Ontario, there's three main ways that we do advanced care planning. The first is identifying your substitute decision maker, or an SDM. This is the person that will speak for you if there ever comes a time when you cannot do so for yourself. The next step is talking to this person and making sure that they feel comfortable speaking on your behalf for you down the road if needed. And then engaging in a conversation with them about your hopes, your worries, trade-offs, what really matters to you. And then talking to your healthcare team afterwards to let them know about that conversation and what you talked about. Next slide. Advanced care planning is not consent for future care. So in the moment, if you need a medical treatment, you need to make, or your substitute decision maker, a decision in the moment about care. And we don't have a way where you can make a treatment decision today for down the road. And that's why we do advanced care planning. We will map out what matters most to you to help the doctors and the treating team make decisions with you or your substitute decision maker down the road if treatments are required. So why should you have a plan? I think if we learned one thing from the pandemic, and we probably learned many things, it's that the world can change upside down in a moment's time. And we heard this also from Karen as well. Things change and things can change quickly. And so having a plan can help in many ways. And so without having legal documentation to consent for future care, it's important for you and your substitute decision maker to discuss what matters most to you to direct care treatment plans in the future. Next slide. So what is an SDM, or substitute decision maker? This is a mentally capable person of understanding proposed treatments and also appreciating the consequences of consenting to or refusing that treatment. They have to be 16 years of age or older and willing to act as your decision maker if needed, and available to speak to a clinical team if called or at the bedside. In Ontario, there is a legal hierarchy that is laid out for every one of us in terms of who our decision makers will be. We always go from top to bottom here. So the top three are legally appointed, and the scenario that we most commonly encounter is that someone has done some planning and has assigned a power of attorney for personal care and has completed a form notifying the treating team that this is the person that would speak for them if they cannot. We move down this hierarchy if that hasn't been done or there isn't someone legally appointed. So as soon as we get to the level that makes sense for that person or that is accurate to their family tree, that is, or those are the people that would be the legal decision makers. And that's automatic, as you can see. So if we look at number 4, if someone has a spouse or partner, that would be their decision maker. If that doesn't apply to them, we would move down. So a child or a parent. If an individual has 4 children, it's important to note that all people at that level hold equal decision-making authority. So all children would have to be at the table making decisions, and to come to some agreement, we can't just go to one instead of the other. And if you wanted one over the other to be making decisions, that's when you would complete a power of attorney for personal care form. So it's important to note that what we're doing in the hospital when we see a patient who hasn't thought about this, or who can't give us the power of attorney document, for example, is we're going through this hierarchy to find the most appropriate person legally next in line to make these decisions. And I think what we see is that this can pose a lot of stress for families if they haven't had conversations together when there's multiple people on one line having to come together and make really difficult decisions during tough times. Next slide, please. I'll also just point out the most important thing to know is that if you have no one that will speak for you, we have an Office of the Public Guardian and Trustee that will work in your best interest with the treatment team to give you the best care possible so that nobody has no one that will speak for them. In Ontario, everyone has someone that can speak for them. So an example here is Mr. Au, and he wants his daughter to make decisions instead of his partner, for whatever his reasons may be. So what he has to consider doing is talking to his partner about this, talking to his daughter about this to make sure she is aware of his hopes and wishes, and being in agreement that she wants to take this on. Then he needs to complete a power of attorney for personal care form and update his healthcare team about this. So the way he can do that is you can go to the next slide, it's free. Many people ask us, do I need a lawyer? Do I need to pay money for this? And the answer is no. You can do this independently or with someone from your healthcare team. You can get the power of attorney for personal care form by clicking on the link there or scanning the QR code or talking to anyone at UHN or your primary care office for this form. Next slide, please. It's fairly basic to complete too. I think people worry that these are very involved forms. There isn't a lot of legalese speak on this. The yellow arrows are the parts that you would need to complete. So you need to write your name. You need to write who you're appointing to make your decisions. The second arrow on the left is saying whether you want, if there's more than one person, if you want them to be able to make decisions together or separately. And it tells you what to write in order, in accordance with your wishes. And then on the right-hand side, you need to sign the form, date it, and put your address. Then you need 2 signatures from witnesses, and that's the 2 pink arrows there. So that is all that's needed to assign a power of attorney for personal care in Ontario. And any healthcare provider, a social worker, a physician, a nurse can help you complete this. And your primary care doctor or anyone on your care team, specialist offices can help out if needed. And I'll pass it off to Dr. Kaya to continue.
Thank you, Dr. Lewin. Good afternoon. Our patients are surviving cancers and living well into old age due to advances in medicine. Patients who would have previously died are now often able to live better and longer. There's a lot of information on medicine in the media. Most of these are breakthroughs and advances in treatment. Accepting death under these circumstances is more difficult. Patients and their families may find it hard to understand that there's a limit to our ability to prolong life. We know that patients and clinicians tend to consistently overestimate the benefits of treatments and underestimate the harms. This leads to an avoidance or a delay in having these discussions about disease progression, disease recurrence, death, and how to plan for this inevitable outcome. Next slide, please. So why should we talk about this? Well, talking about things that we can't control, believe it or not, can actually help give us a sense of control. There are many studies that show that as we feel more in control, our anxiety is lowered. Proactively discussing what's important to us helps us to advocate for better quality of life and improves our satisfaction of the care that we receive. Importantly, it can help us to make the best choice for our care based on our individual circumstances and leads to less days in hospital when we are sick. Next slide, please. So everyone should be having these discussions, and there are many opportunities for having these discussions during your disease trajectory or disease course. An acute medical issue that requires hospitalization is often when these discussions are initiated, but making difficult choices during a health emergency is less than ideal, especially as you may not be capable of participating in a conversation. Your family will feel less burdened by decision-making on behalf of you if they have been involved in these discussions while you are still capable. It would be better to have these discussions when you're feeling relatively stable and able to participate in a conversation, such as when you're informed of a progression in your disease during routine surveillance in clinic, for example, or when you yourself recognize that you have noticed a change in your physical abilities. You may find that you're no longer able to do certain chores, such as cooking or cleaning or grocery shopping. This is a good time to broach this conversation. Next slide, please. It's important to feel confident about asking questions about the future and your health with your healthcare providers. You know, none of us feel confident and comfortable about having these conversations. Patients don't bring it up, doctors don't bring it up. So it's really, really important that you feel confident to be able to tell your doctor or nurse or care team member to say, I'd like to put advanced care planning on our agenda. Healthcare professionals are busy, they don't have a lot of time, and they often avoid these discussions because they have a false belief that this will take away your hope, lead to depression, and decreased survival. Most healthcare professionals were not taught how to do this using an evidence-based method. It's not top of mind when things are going well, but we're trying to change this. Thinking about this conversation prior to meeting with your healthcare provider can really help you make the most of the short time that you have with them. Both goals of care and advanced care planning discussions can be really scary to think about. It might be helpful to practice out loud in front of a mirror before you meet with your healthcare provider. You might have to use words that are scary or difficult. It's important to know that using these words do not make it more likely to happen. And here in these cloud bubbles, these are some of the things that we've come up with that might help get you thinking and reflect on your own circumstances. In the interest of time, I'm not going to go through all of them. You can go to the next slide, Melissa, thank you. So, bringing a family member or a friend can act as your second pair of eyes and ears. Some people also find that keeping a journal can be helpful for keeping track of information. Your journal can be a paper journal, it can be an electronic format, whatever works best for you. And your family doctor can be extremely helpful as well for liaising between all the different clinical teams and ensure that you and your family have the support that you need to navigate the various pockets of care that you receive, acting as the constant in between all of that. And this partnership with your healthcare team really combines your clinician's expertise, who can give you information about treatment options, evidence, the risks and benefits, with you, what you know best yourself, your preferences, your personal circumstances, your goals, your values, and your beliefs. Next slide, please. And just remember that it's really, really important and critical. And the things I think that we'd like you to take away with regarding these is really just think about, identifying your substitute decision maker based on the information that Dr. Lewin presented, and then starting to reflect on what really matters to you and having this discussion with them and ensuring that your team knows about this as well. Next slide, please. And don't forget, I'm hoping that at the end of this, you'll feel confident and empowered to be able to go up to your healthcare team and say, can I book an appointment, please, to discuss advanced care planning with you? Thank you, and I'm going to hand over to Dr. Hannon.
Thank you, Dr. Kaya. I'm going to chat for the next 10 minutes or so about palliative care and how it might be relevant in the context of what we're talking about today. So this slide is meant to be a little bit humorous, but it actually does ring quite true, as we've already heard from some of the other speakers. Many healthcare providers simply do not feel comfortable talking about advanced care planning. And this is one of the areas where the palliative care team can really be of benefit and assistance to you, your family, and your healthcare team to address the concerns and questions that you may have. So palliative care is unique in that it is both a philosophy of care and a medical specialty, which is provided by a team with the goal of improving your quality of life for people living with advanced serious illnesses and their families, regardless of the underlying diagnosis. Although many people associate palliative care with cancer, this is simply not true. And we also provide palliative care to patients with end-stage heart, lung, liver and kidney diseases, as well as neurological conditions and AIDS. Anyone at any age with an advanced illness can receive palliative care. And it's also really important to note that palliative care is not just relevant at the very end of somebody's life when their active care has stopped. More and more, we're getting involved with patients much earlier in the course of their advanced illness and providing side-by-side care with their care providers, their oncologists, their cardiologists, to really make the transitions as smooth and easy as possible. So how can palliative care help? It can help by managing your symptoms, be they physical or psychological, to reduce the stress and anxiety experienced by patients and their loved ones associated with an advanced illness. It can help to facilitate effective communication between patients and their care providers, patients and their families, and be an empathic presence, somebody who can be there to support you through it all. And as my colleagues have already spoken to, palliative care is not about removing hope or being grim or negative, and rather sometimes being able to have these conversations and to open dialogue around your wishes and your values can foster hope and optimism among people. So what does palliative care hope to do or not hope to do? Well, palliative care neither hastens death nor prolongs life. Its main aim is to help you feel as good as you can for as long as you can. It helps you to maximize living in the time that you have in a way that is personally meaningful to you. And the focus is very much on improving your quality of life. Patients tell us that when they're faced with a serious illness, these are the things that they value. They want their pain and other symptoms to be well managed. They want to be able to make decisions in collaboration with their families and with their care teams. They want to achieve certain goals and complete life tasks and be able to continue to contribute meaningfully to others. They want to be seen as something more than just their illness and to get affirmation of themselves as a whole person. And they also want to be able to speak about and prepare for death. Here are some myths that sometimes people feel about palliative care. We're going to try and debunk some of them today. Palliative care is not only for patients who are very close to the end of their life or who are actively dying. We see patients now months and sometimes years before they die. Palliative care does not mean that a patient's care team has given up and that there is no more hope. Rather, there's a greater acceptance that palliative care teams have a specific skill set that can really enhance somebody's experience as they're going through a serious illness and help them live better and sometimes live longer. Palliative care can be provided in a whole variety of settings, not just in the hospital. Often patients worry that pain is an inevitable part of the end-of-life experience. This is simply not true. Many patients and their families worry that taking medications such as opioids or narcotics will cause addiction or tolerance, and that is also simply not true when it's prescribed appropriately. Opioids or narcotics do not hasten somebody's death or make death happen faster. And finally, many people worry about talking to children about death and dying and feel that it may not be appropriate. Our research and our evidence shows us that this is not true, and that when it's dealt with sensitively and appropriately, it is completely okay, and in fact is the right thing to do to talk about children about this. Moving on to some of the palliative care supports here at UHN. The good news is that palliative care is available at all UHN sites, regardless of where your care team is situated. We can help you and those who care about you in many different ways. We can help you to manage some of these bothersome symptoms. We can help to have frank discussions with you about what matters most to you and your family, and to help to guide your treatment plans along with your care team around your values and wishes. And we can also help you to coordinate your care and to navigate the healthcare system, which we know can be very tricky and convoluted, so that you will continue to receive the best care, be it in the hospital, in your home, or wherever you may be. And you can ask your healthcare team about available supports or about palliative care at any time. We've got lots of brochures. We're going to give you some examples of those over the next few slides. You can learn more about the palliative care program using this pamphlet. You can click on the website or scan the QR code using your smartphone or your QR code reader to get direct access to this. And if you want more information, we have even more pamphlets. around exploring your palliative care options. We have guides which are written by our UHN healthcare providers to help you understand the speak up work that Warren spoke to earlier on around substitute decision makers, as well as other parts of your palliative care options that you can be engaged and involved in from early on. If you're making healthcare decisions for other people and you are that substitute decision maker or that primary caregiver, we also have great resources and pamphlets that may be of use to you. And the good news is these are available freely throughout UHN and also available in many languages, recognizing that many of our patients and their caregivers come from diverse parts of the world, just like Dr. Kaya and myself, and for whom English may not be their first language. We've heard about Speak Up Ontario from Karen and from Warren earlier on. This has Ontario-specific information and tools to help you have these important conversations about your future healthcare decisions, including advanced care planning, and with updated content related to COVID-19. If you still can't find what you're looking for, there's even more. You can contact the UHN Patient and Family Library. Here we have trained health information specialists who are amazing. I can tell you I've worked with them myself on many occasions, and they are extremely helpful and supportive. You're always welcome to contact them. They offer reliable and up-to-date health information for our patients, for their families, as well as for us and for members of the public. And again, these services are free and are available in many different languages.
Thank you so much, Dr. Hannon and Karen, Dr. Lewin, and Dr. Kaya. So that brings us to the end of the presentation component of our health talk. And on behalf of our participants and patient education program, again, I would just like to thank our speakers for sharing your expertise and experience about planning for future care. So we'll now take a look at the Slido to see what questions have been submitted. You can still submit questions if you haven't already. And to do so, please go to slido.com and enter UHN Health Talk, that's one word, in the event code. And just as a friendly reminder, you can choose to include your name or stay anonymous, but we ask you to note that others will be able to see your name if you do include it. So we'll take a look at the first question, starting from the top. I'll just highlight this. So somebody has asked or said, my partner's prognosis is about a year with incurable cancer. Discussing death or the fact that his illness is incurable is very painful for him. He is desperate for a cure and has no interest in advanced care planning, even if posed as good to have just in case. Any thoughts on the situation?
I could start, I guess. So I think you raise a good point in that it's difficult to have these conversations, and Karen spoke about that initially. These are tough conversations, and in our culture, death and dying is not something that is front and center for most of us. And so talking about it is difficult. Know that there are teams available to help and specialists available to help make this difficult situation a little less difficult. And so depending on where your care is and your partner's care is, I would speak with their permission to get information from someone on the team to help. You know, as Dr. Hannon had mentioned, there's so many of us at UHN who can help in this regard. It doesn't make it easier, but we can give you the tools and we can help shepherd you through these tough conversations. And most people feel that talking about this at some point actually lessens the burden of what's going on, but getting to that conversation can be challenging. And also advancedcareplanning.ca does have great tools for starting the conversation as well. So, you know, one-liners that start the conversation, and that can be helpful if you wanted to go to advancedcareplanning.ca and specifically talk to your doctor, talk to a nurse, talk to a social worker, and say help, and there can be some tools available.
Thank you, Dr. Lewin. That's a great resource to know about. Okay, so now we'll see the next question. Somebody has asked, how do I revoke a power of attorney if it's not working well?
Hi, my button's finally working. Sorry, I was trying to unmute myself for the previous question, but I couldn't. I'm hoping that you'll feel much more confident about this, having kind of watched Dr. Lewin's segment. So you just have to go and change the name if you're not happy with who's on that list of hierarchy that we explained for your substitute decision maker. If you're not happy with who would be based on that hierarchy for you personally, then you just fill out that power of attorney form, naming the person who you would prefer. And make sure you let your healthcare team know as well.
Thank you, Dr. Kaya. Was there anything that you wanted to add for the previous question before we move on to the next one? Yeah.
No, I think Warren did a fantastic job. I was just thinking, now reflecting on it, sometimes, sometimes having this conversation with a stranger can be easier. So occasionally, very occasionally, when I bring this conversation up, when I'm asked to meet with patients for the first time, family members can be surprised at how forthcoming or how open patients are to having this discussion with us, having tried endlessly to bring it up themselves. So you never know, it might be that, speaking with somebody outside of the family is easier. And once we've started to have that conversation, then we can help make sure that communication between the patient and the family member becomes a bit easier as well.
Thank you, Dr. Kaya. Okay, so for the next question, sorry, my slider was a bit slow today. So somebody has asked, can you explain the difference between an advanced care plan and a living will or advanced directive? Do I need a lawyer for any of these plans?
I think Warren has already spoken to this quite nicely in the presentation, so hopefully this is more clear. Just to reiterate that in Ontario, living wills and advanced directives are not legally recognized. And so highlighting even more the importance of having an advanced care plan and having open and frank discussions repeated over time, as Karen said so beautifully in her introduction, with your family, with your loved ones, and with your healthcare providers, letting them know what's important to you, what you would prioritize, and how you would like your care to be delivered should something happen in the future when you're not able to speak for yourself.
Thank you, Dr. Hannon, for summarizing that. Okay, the next question. So somebody has asked, if I create an advanced care plan and share it with my care team, where will this information be stored? How can I be sure all members of my care team at UHN and if I go to another facility are aware of and follow my wishes?
So I can jump in. We are all very excited about EPIC, which is the Electronic Medical Health Information System launching in June at UHN. There is a advanced care planning section that you will be able to access through the patient portal on your end, where you can upload your advanced care plan, where you can upload your power of attorney document, where your doctor or healthcare team members can do the same. So there's going to be a better interface between you and the healthcare team on this topic. So having said that, the different hospitals and different clinics oftentimes don't speak to each other outside of UHN, that is. And so it's always a good idea when you land in a hospital, if that happens to you, that you talk to your team and say, I'd like to make sure that you have, this document updated in my chart. I want to make sure that you know who my power of attorney is or substitute decision maker is. I think we are training people as much as we can to be the ones asking. And I think with our new health information system, EPIC, this will help us have more transparency and help people have more comfort with these conversations. But just to say that it doesn't often get translated between institutions and even within the institution. So while this is a work in progress, It's always important if you can advocate for yourself, and we will continue advocating as well on our end.
Great. Thank you so much, Dr. Lewin. Okay. Our next question. Somebody has asked, are there any good movies which would act as a touchstone for the difficult conversations for end of life? So for example, The Notebook was a great one for dementia. I don't know if any of our speakers know of any other resources. Oh.
Oh, sorry, Karen, did you want to say?
No, I'm just thinking.
They're turning Being Mortal, the book that we recommended, into a movie. And so that should be coming out in the next couple of years. There is one about a woman with ALS, and I think it's Susan Sarandon that plays it. I'm going to do a quick search and get back to you.
Thank you. So whoever has asked this question, we can look into this some more for you. If you'd like to email us with your question, then we can get back to you directly. Our email is pfep@uhn.ca, and this email is also in the description box below. Thank you. It's great to know that there's more in the media about this topic too, so more people can be educated in different ways. Okay, so the next question asks, how come the substitute decision maker does not have to be competent, but the patient has to be measured or evaluated? I'm wondering if this question maybe touches on the eligibility of being a substitute decision maker.
I'm not sure I understand the question. I'm not sure the patient has to be, perhaps they mean that because the way our law governs the way healthcare decisions are made, we have to obtain consent for treatments. And in order to obtain consent from a patient, you have to be capable. So your healthcare team having or obtaining consent from you has to be able to determine if you have that capacity, if you're capable of making those treatment decisions. And if they deem that you're not, that's when they would go to your substitute decision maker to be able to obtain consent for whatever it is that they're proposing. I think that's what you're asking. I hope so anyway.
I think this question.
So if the person on the list, on Warren's list, was not necessarily the person the patient would go to, I guess the person is asking, what if you choose off that list someone who isn't competent? It's a kind of complicated situation.
Yeah, and to answer that, a substitute decision maker has to be competent. They have to be able to understand the person's illness and appreciate the consequences of choosing to opt in to receive a certain treatment or to decline that treatment. And that's in the moment. So if today somebody chose an SDM that is competent today, but down the road, and signed a power of attorney form for personal care, and then down the road, that person unfortunately is no longer capable in that moment, then we would have to then go back onto that list to see who the next person would be.
I think this question is also asking, like, how is that determined whether that SDM is capable? I guess it would be during those conversations with the healthcare team. The healthcare team is gauging that as their, okay. Thank you. Okay. Next question. So where can a person find, if it exists, a wait list for palliative care in Toronto, since other healthcare wait times are accessible online? So I guess we can start with the first question. Is there a wait list or like some way for people to find out how long it would take to get palliative care services?
Thanks, Melissa. I can start with this one. I think it depends on the question and whether somebody's asking about wait lists to be admitted to a hospice or a palliative care unit, for example, or if they're talking more about to see a palliative care doctor or team in the hospital or the outpatient setting. I think when we think about wait lists for hospices or palliative care units, sometimes people confuse it with the long wait lists for long-term care and nursing home care, which is obviously shocking in many different areas. And the good news is we do not have wait lists of this kind for palliative care units or hospices in Toronto. It really changes from day to day. It's a very dynamic wait list, but usually for somebody who needs to be admitted quickly to a hospice or a palliative care unit, this can happen within a short number of days, typically. If you're waiting to be seen by a palliative care team in the hospital or the outpatient or at home, again, it can be prioritized. And if your situation is very serious or there's something very acute going on, you will be prioritized and you will usually be seen within a short number of days. In the hospital, our teams will always try to see patients who are referred to us on the same day, if not the next business day. So very, we try to be very responsive to the needs of our patients and their families, and really try to meet people as quickly as we can, depending on their circumstances and the sort of the symptoms and issues that they're dealing with.
Thank you, Dr.
I might just add also that if someone is wondering from this question, just to proactively plan, if they know there's a palliative care unit or a hospice that they would like to be in and they want to try and avoid the hospital at end of life, you can get put on a backup. You can fill out an application alongside your family doctor or your community team to get you on what's called a backup list for a specific unit of your choice. So for some people, they really want, Kensington Hospice, or they want a Baycrest unit, or they want, Dorothy Lay Hospice, a facility in the community that is really near and dear to their heart. You can go visit these places. You can take a tour outside of COVID times, but anyone will always be able to talk to you on the phone about this and actually have a backup application that you would talk to your healthcare team about acting on down the road.
Great, that's great to know. Thank you, Dr. Liu and Dr. Cannon. So I'm just being mindful of the time, and I noticed it's already 1:58 p.m. So unfortunately, we'll need to wrap up our session. So thank you everyone for submitting your questions, and thank you so much to our speakers for answering them and sharing more of your expertise. If we didn't get a chance to answer your question, I'm really sorry. Please email us at pfep@uhn.ca and we'll try to respond within 1 week. Again, your feedback is important to us, so please go to the link on your screen and complete the survey. This link is also in the description box below for you to easily access. And you'll also be able to enter a chance to win a $10 Tim Hortons gift card if you fill out that survey. And just a quick reminder again, that link to the survey will be in the confirmation page of your completed survey. And to fill it out by Thursday, May 5th at 2:00 p.m. because we will draw the name and notify the winner on the Friday. And again, make sure to enter your email address correctly and to check your spam or junk folders in case we reach out to you if you're the winner. Finally, to find out about our next talk, subscribe to our online patient newsletter and get up-to-date information about events and new resources at UHN. And to subscribe, just fill out a form, and the link on your screen will get you there. And it's also available on the confirmation page of the feedback survey if you're filling that out right now. Again, thank you so much for attending today's health talk. And I want to thank Karen, Dr. Lewin, Dr. Kaya, and Dr. Hennon again for your time and all the effort you put into putting together such a great presentation today. Thank you again, everyone, and we hope to see you at our next talk in May.